This is The Rounds Table. All right, welcome back. A new episode. This is a Trial Files birthday edition. Yes, Trial Files is now 2 years young, so we thought it would be fun to recap the top 5 trials that have been included in Trial Files. If you're new to Trial Files, it's a newsletter summarized by yours truly and many others, generated by AI and free to your inbox twice a month. Okay, what did we have up first? Effects of semaglutide on chronic kidney disease in patients with type 2 diabetes. This was published in the New England Journal of Medicine in May 2024. So just a quick reminder, this is a randomized trial with a median follow-up of over 3 years that evaluated the efficacy and safety of subcutaneous semaglutide at a dose of 1 milligram per week in patients with type 2 diabetes and chronic kidney disease. The primary outcome was major kidney disease events, and that was a composite of onset of kidney failure, defined as dialysis, transplantation, eGFR of less than 15. It also included at least a 50% reduction in GFR from baseline or death from kidney-related or cardiovascular causes. So what did they actually find? So what they found was a 24% relative risk reduction in the semaglutide group compared to the placebo group, which is pretty impressive. Secondary outcomes, they looked at the mean annual eGFR slope, the risk of major cardiovascular events, as well as some other outcomes, and these generally favored semaglutide. Serious adverse events were reported in a lower percentage of patients who got semaglutide compared to placebo. So this article, really, its take-home closing point was that semaglutide reduced the risk of clinically important kidney outcomes and death from cardiovascular causes in adults with type 2 diabetes plus chronic kidney disease. This was impressive, and I never would have guessed that semaglutide would improve renal outcomes, but there you go. For my patients with type 2 diabetes, I do everything I can to get them on a SGLT2, plus or minus a drug like semaglutide. The hard part with semaglutide is the cost, right? So in Ontario, if you're over 65 and you don't have diabetes, it can be prohibitively expensive. But if you do have diabetes, it is covered. And I think people are aware of this, but bears some repetition that the important adverse events with semaglutide are diarrhea, nausea, constipation is the other one. So I've seen a few patients, older adults, hospitalized with constipation from semaglutide, and they come in quite delirious. And then another important adverse event is fatigue. 10 to 15% of patients can get pretty bad fatigue while on semaglutide. Okay, 1 down, 4 to go. Next up, restrictive or liberal transfusion strategy in myocardial infarction and anemia. This was published in New England Journal of Medicine in November 2023. Quick recap. It was a randomized trial of a liberal transfusion strategy, so using a hemoglobin cutoff of less than 100 or less than 10 in American units, and compared that to a restrictive strategy, where instead you would only transfuse the patient if their hemoglobin was 70 or 80, and again, in American units, that's 7 or 8. It included 3,500 patients, and all came in with acute myocardial infarction, and at baseline, they had a hemoglobin of less than 100. So their primary outcome was a composite of MI or death at 30 days. And, between the two groups, the mean number of red cell transfusions was approximately 1 in the restrictive strategy group and 2.5, let's just round that up to 3 in the liberal strategy group. So what did they find for that primary outcome? Well, overall, 16.9% of patients in the restrictive strategy group and 14.5% in the liberal strategy group experienced the primary outcome of MI or death. So said simply, a lower risk with the liberal transfusion arm, which was surprising. I think we're taught in residency, less is more with blood products, and in general, we should only be transfusing a patient if their hemoglobin hovers below 70. Of course, an exception is if they're bleeding. This study also looked at safety outcomes, and no key safety outcomes that were different between the two arms, no increased risk of heart failure in the group that got more blood. So, overall, this study found that a liberal transfusion strategy it might reduce the risk of MI or death at 30 days. And the reason why I say might is because the point estimate just barely crossed 1. I won't go into all the details here, but there has since been an individual patient data meta-analysis for the results of this study and other trials. And it sure seems like for patients who are coming in with acute MI and a hemoglobin less than 100, we should probably be targeting a higher transfusion threshold. Me personally, if those patients dip below 90, at that point in time, I'm giving them a unit of blood. All right, 2 down. Next up, back to semaglutide. This time, once weekly semaglutide in persons with obesity and knee osteoarthritis. Obesity is common. Osteoarthritis is also common. So, quick recap. This was a 68-week double-blind randomized placebo-controlled trial that compared semaglutide once weekly 2.4 milligrams compared to placebo. And the primary outcome was related to pain. They used a validated score called the WOMAC pain score. Overall, 400 some odd patients were included, and the primary outcome, as mentioned, was this pain score as well as reduction in body weight. Kind of odd that they included that because we know this reduces body weight. But anyway, I'll go back to the script. So overall, they showed a 14% reduction in body weight with semaglutide and a 42-point reduction in the WOMAC pain score with semaglutide. This compared to a 3.2% reduction in body weight with placebo and a 27-point reduction in the WOMAC pain score with placebo. So, overall improved weight loss and also improved pain, right? Like that delta, 41 minus 27 is like 14 some odd points. If you're curious, when patients get a knee replacement and you assess their WOMAC score before and after a knee replacement, generally it falls by about 20 points. They also looked at adverse events, which was similar between the two arms. Certainly there's more nausea and GI side effects with semaglutide. And, overall, the summary statement here is that treatment with semaglutide resulted in significantly greater reductions in body weight and pain related to knee osteoarthritis compared to placebo. I thought this trial was pretty neat. If we think about like surgeries that we no longer do because of medications that work really well, the best example I can think of are PPIs. Before PPIs, general surgeons were, resecting parts of people's stomach to treat a severe ulcer. And of course, that surgery almost never occurs anymore, at least not in, developed countries. And, will semaglutide put orthopedics doctors out of work? I don't think so. But I think it's very reasonable that if you have a patient who has obesity and they have knee OA or hip OA, maybe before you jump to a joint replacement, you start with semaglutide and see how much it improves their symptoms. Anyway, hopefully I didn't insult too many orthopedic surgeons. However, I don't think there's a single orthopedic surgeon who listens to this podcast. All right, next up, antibiotic treatment for 7 versus 14 days in bloodstream infection. This was the BALANCE trial published in the New England Journal of Medicine in November 2024. So a quick reminder, this was a multi-center, non-inferiority trial that included 3,600 hospitalized patients with a bloodstream infection, and they were randomly assigned to get 7 or 14 days of antibiotic treatment. Key exclusion criteria, so it excluded patients who had Staph aureus bacteremia, it excluded patients with candidemia, it excluded patients with febrile neutropenia, it also excluded patients with an undrainable abscess. If you had an abscess and it could be drained, they were included. They also included patients with immunocompromise, so patients with cancer, on chemo, or patients on high dose of steroids, they were included in this study. So the primary outcome was death from any cause by 90 days, and they used a non-inferiority margin of 4 percentage points. So what did they find? So for this primary outcome of dead at 90 days, that occurred in 14.5% of patients in the 7-day treatment group and 16.1% of patients in the 14-day treatment group. So if anything, it suggested a potential benefit, all right? That's a negative 1.6, or I should just say a 1.6 percentage point decrease in death in the 7-day group. However, confidence intervals spanning from -4 to 0.8. So clearly, this was non-inferior. The study also found that patients were sometimes treated more than 7 days, even in the 7-day group, so about 23% of the time. And in the 14-day group, sometimes patients got more than 14 days of antibiotics, and that occurred in about 10%. The study included a number of subgroup analyses. Did it vary by gram-negative versus gram-positive? Nope. They also saw a shorter length of stay in the 7-day group, and maybe, just maybe, potentially a lower risk of C. diff. So overall, this study concluded that 7 days of antibiotic treatment was not inferior to 14 days of treatment for hospitalized patients with bloodstream infection. I was a site lead for the BALANCE trial, so know it relatively well. And important to also note that it included both critically ill patients who were in the ICU as well as patients on the inpatient ward. There's now another trial going on called the BALANCE Plus trial. That's going to focus just on gram-negative bacteremia. And it will answer such questions as, let's actually randomize patients to Cipro versus amoxiclav and see which one does better. Okay, that is 4 down. Last up, Finerenone in heart failure with mildly reduced or preserved ejection fraction, published in New England in 2024. So this was the international double-blind trial that evaluated the efficacy and safety of Finerenone. Finerenone is a non-steroidal mineralocorticoid receptor antagonist, and it's kind of like spironolactone, but felt to be safer, lower rates of like hyperkalemia, for example. And as mentioned, it was patients with heart failure with mildly reduced or preserved ejection fraction. So 6,000 patients were randomly assigned to receive Finerenone or placebo. The primary outcome was a composite of total worsening heart failure events and death from cardiovascular causes over a median of 32 months. What did they find? So Finerenone resulted in a significantly lower rate of the primary outcome compared to placebo, like a 15% relative risk reduction. Safety outcomes did show increased risk of hyperkalemia with Finerenone. So overall, authors found that Finerenone was effective in reducing the rate of the primary outcome in patients with heart failure and mildly reduced or preserved ejection fraction. For me, this trial hasn't yet changed my practice. It's partially just related to where I work. So in Ontario, Finerenone is not covered for heart failure for patients who are over 65. So that is a barrier to its use. It is covered if you have chronic kidney disease, but I'm curious to hear from maybe cardiologists who listen to this podcast. Has this been a game changer of a study for them? An unanswered question for me is, okay, and how effective is Finerenone in this patient population with, say, preserved EF heart failure if they're already on an SGLT2? Like, what is the delta benefit that it brings? Anyway, that's, I think, all I'll say about that trial. So yeah, just to close out, that was top 5 trial files over the past 2 years, because Trial Files turns 2. Shout out to the larger Trial Files team: Katerina Zorcic, Emily Barch, Brian Lim, Genevieve McCallum, Tamara Van Bakel, Danielle Cutler, as well as Allison Hacker. Hope you enjoyed this. If you did, write us a review. That's super helpful for us. And share Trial Files with your colleagues, with your friends. Heck, even with your foes. You can share it with them too. All right, that's it. Stay well and take care.
The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X. And special thanks to our audio editor, Tamara Van Bakel.